For those who are just tuning in, welcome back to APAICS Health Summit. I'm Madeline Milka, President and CEO. I'd like to extend a warm welcome to our next speaker, KPAC Associate Member, Congressman Mark DeSaulnier. Congressman DeSaulnier proudly represents California's 10th Congressional District and currently sits on the Committee on Education and Labor, where he serves as ranking member of the Subcommittee on Health, Employment, Labor, and Pensions. He also sits on the Committee on Transportation and Infrastructure and the House Committee on Ethics. He is also the founder and co-chair of the Bipartisan Cancer Survivors Caucus and a member of the Mental Health Caucus. Prior to his time in Congress, he served as a California state senator and assembly member, where 61 of his bills became California state law. Please welcome Congressman DeSaulnier.
Hello, everyone. Thank you so much for asking me to give these few comments as you start your conference. I am delighted that I'm a new member of KPAC from the House Caucus. Very, very happy that I was invited to join my new district. My old district was very diverse, and the new one is as well here in the Bay Area, in San Francisco Bay Area. So thank you for what you do. Thank you for allowing me to be part of your community. And on the issues of health, physical health and mental health, those are preeminent in my public service career as a member of the Health, Employment, Labor, and Pensions Subcommittee of the Education Labor Committee, as the former chair and the current ranking Democrat. This is important to me professionally and personally. Personally, as a survivor of non-curable cancer, I am very attuned to the services I've gotten and how grateful I am for the fabulous researchers we have in this country who've contributed to me to be able to survive my cancer and live a normal life. But I want that for everyone. Well, I'm sure we all want that for everyone. Taxpayers have paid for much of this research in this country, and the benefits of that research and the deployment of that through our health system is important to me for all communities. So very grateful that you've asked me to be part of this. Look forward to continue to working with KPAC on your efforts to make sure that healthcare, in particular in this instance, is available to all Americans, and in this instance, make sure that your voice is heard. Thanks so much.
Thank you for joining us today, Congressman DeSaulnier. Our next panel is on innovation in the healthcare industry. In healthcare, the term innovation can apply to the development of new therapies, drugs, or medical devices. However, we have also seen unprecedented acceleration and adoption of innovative healthcare technologies as a direct result of COVID-19. As our nation continues to improve our healthcare system beyond the current pandemic, innovation must be explored in a broader context, examining previously underdeveloped opportunities in areas such as access to care, data analytics, consumer behavior, provider incentives, and process improvement in care delivery. Our moderator for this panel is Dr. Richard Pan. Dr. Pan is a pediatrician and senior policy advisor to AAPI Data. Formerly, he served as a California state senator and immediate past chair of the Asian American Pacific Islander Legislative Caucus in California. Prior to serving in the legislature, Dr. Pan was a University of California Davis professor and director of the Pediatric Residency Program, where he established a nationally recognized service learning curriculum on child advocacy and social detriments of health, communities, and health professionals. In the legislature, Dr. Pan served as chair of the Assembly and Senate Committees on Health and chair of the Senate Budget Subcommittee on Health and Human Services, and he authored key legislation on Affordable Care Act implementation and coverage expansions, public health, including vaccination and civil rights. As a policy chair, Dr. Pan led passage of the $165 million AAPI equity budget in 2021. Let's welcome Dr. Pan and our third group of panelists.
Hi, I'm Dr. Richard Pan. I'm a pediatrician and a former California state senator, and I was the former chair of the API Legislative Caucus in California. But as a physician, I'm so very excited to be able to moderate this amazing panel of leaders to talk about healthcare innovations and our Asian American and Native Hawaiian Pacific Islander communities. So we have on this panel some amazing people here. Let me just briefly introduce them. We have Charley John, Senior Director of Public Policy at Walgreens. Dr. Tonia Vinton, Medical Director or Weight Wellness at the University of Texas Southwestern Medical Center and president of the Dallas Obesity Society. Sean Oscar, public health informatics specialist with the Alexandria Health Department. Amy Dinkler, chief administrative officer at LCMC Health. And Karen Chung, senior director, health economics and outcomes research at Grail. So again, thank you so much for being here and for participating in this very important panel. And so what I'd like to do is launch off our discussion with you describing your role in your organization in relation to innovation. And as a member of our Asian American, Native Hawaiian, Pacific Islander community, what perspectives do you bring to innovation within your organization? And with that, Charley, would you like to start us off?
Sure thing, Dr. Pan, and thank you for that question. Thank you also to APAICS for convening this session, and really honored to be amongst my colleagues here. We're all very accomplished. I think it's a very important subject, and important to come up with real solutions and policy solutions that help our communities. Just to give you a little bit more about my role in the company, I'm currently serving as our Senior Director of Healthcare Policy. I started off in the company about 25 years ago as a pharmacist on the front lines, and I worked in communities in all through Florida, Chicago, Ohio, the DC region, Maryland, and Virginia. So I mentioned that background because I practiced at a time when pharmacists, pretty much all they did was dispense your medication, hand you a bag of medication, and counsel you on that. And over the 20 years that I've sort of practiced and worked in this policy space, I've seen the role really evolve into a healthcare provider that can provide a much more comprehensive and whole person care. And I think that really is sort of the Walgreens commitment to how we're redefining healthcare moving forward. Our approach is to be local and to be in the community and to provide equitable access to all that live in that community. And it, again, starts from being patient-centric and thinking about the whole person and their care across their continuum, as opposed to just a siloed service here and there. And so I think that's the vision in which we bring to how we're innovating in the healthcare industry. Through that, I think we help expand access to care by not only leveraging our neighborhood destinations, we have 9,000 locations across the country, but also our digital footprint and our ability to interact with patients in so many different ways. We have a very patient-centric approach, and that allows us to create sort of a simplified and frictionless experience for our patients because we have so many varied patients with different needs, and so helping them navigate the process is something very important for us. And through it, I think we help achieve improved health outcomes. It's not enough to just dispense medications and make sure that you just stay on your medications. At the end of the day, you need to have an improved health outcome from having that care. So we're really thinking through a lot of different strategies and programs that help us achieve this. We had started well before the pandemic, but I did want to bring up the pandemic experience in that first, I was very close to the whole vaccine and therapeutics distribution and administration program with the Department of Health and Human Services. I worked alongside the colleagues there at HHS, along in the building, and it was hour by hour managing how we were going to get vaccines and therapeutics into the communities and making sure every American was able to get vaccine. So that experience really helped me understand the inequities that we have in our country when it comes to healthcare, disproportionately affected communities, communities that rarely seek out healthcare or generally do not have a stable source of healthcare. And so it helped us think through that we can't just keep doing what we're doing. We need new strategies to reach those communities. And just one of the very neat things that I think we were able to bring, I mentioned our 9,000 locations, and we vaccinated so many people in the four walls of our stores. But one thing we were able to do is those folks that weren't able to make it into the stores, or perhaps they just weren't sure about getting the vaccine, we went out and we met them in their communities. We conducted nearly 2,000 offsite clinics. And sometimes this involved driving a bus right up into a neighborhood and being able to knock on a door and say, hey, we're right out here on your street and ready to vaccinate. So we did that across the country, rode buses around the country, 2,000 offsite clinics, delivered over 2 million vaccines through those services. And these are people that who can be pretty sure that they would not have gotten a vaccine other than us being there. So I think that's just a quick example of how we are changing. Innovation doesn't always need to be a shiny tech object. It's just a different way of reaching patients and meeting them. And so we were able to do that through that service. But just a quick background, but would love to hear from my colleagues and looking forward to finding ways that we all partner together to deliver more innovative care to our communities.
Well, thank you, Charlie. That's an amazing story. But even as we're struggling with COVID, obesity has been a long-standing problem in our community and across the country. Dr. Vinton, can you speak about your experiences? I mean, you lead the obesity society for your city. So share with us what your role in innovation is.
Thank you so much for your introduction. So yes, I am double board certified in internal medicine and obesity medicine, and I've been practicing obesity medicine now for the last 7 years. I would say more recently, I decided to start the Dallas Obesity Society, which is a nonprofit organization dedicated to educating clinicians about obesity as a chronic disease and treatment opportunities, because it is estimated that by 2030, over 50% of Americans will actually be in the obese category, and that's a BMI greater than 30. And as of 2019, also, there are only 2,500 obesity medicine specialists out there, which means there are 11,000 patients that need obesity treatment for one obesity specialist. So clearly, obesity education is very much needed. So the Dallas Obesity Society has been working on doing a lot of educational seminars since its inception. And more recently now in the last year, we're really looking at kind of changing pace to bring obesity education specifically tailored through wellness programs for physicians. Because it's the thought that, if we help physicians learn lifestyle modifications for themselves, they should see improvements in their own health, and hopefully this will empower them to have conversations and begin treatment for obesity in their patients. So specifically in these wellness programs that we're targeting to physicians, we're going to be discussing nutrition and lifestyle strategies, and specific to Asian physicians, definitely kind of talking about appropriate dietary changes that would be helpful and impactful. A lot of the times, I think Asians kind of have this complaint that, hey, the diets out there that help with weight loss, like keto diet or Mediterranean diet, South Beach diet, those are foods for other people. These are not culturally appropriate or palatable. So that means there's really no diet for me, right? So a lot of our strategies that we're going to be teaching are actually maybe some innovative cultural swaps, reinventing our recipes. So using, say, cauliflower rice and fried rice, and using low-calorie konjac noodles in our food, pho soups. And hopefully this will help them transition into a healthier diet state. And then also from there, be able to feel confident to translate that to their patients in their practice.
Thank you, Tonia. And that's a great story about, again, how do we be sure our community can connect with these interventions that everyone talks about, obesity. So Sean, you're a health department, so definitely the front line of COVID. Health departments tell me about what your work in the health department has been as we've been struggling with this pandemic.
Yeah, absolutely. And first I want to say thank you to you, Dr. Pan, for moderating this, to Madeline and APAICS for hosting and also inviting us to participate. And I think this conversation is incredibly valuable to talk about innovation, because especially as you said, in the pandemic, like, public health departments were a primary response vehicle for any number of components of the larger pandemic response. So it's been important for us to start looking at what can we take from the COVID-19 pandemic and kind of apply moving forward. So my role as the public health informatics specialist at the Alexandria Health Department is to sit kind of at the nexus of data and data science, technology and technology acquisition, and then operations optimization. And so what I get to do, which is really cool because the health department never had an informaticist before, is to look at all the different data sets that we're capturing and cataloging and try to understand, are those the right data sets that we have, or do we need new ones? And then how do we analyze them? Do we need new tools and new technology solutions to better implement the care options that we have on both the communicable and the non-communicable sides? And then finally, can we use that information on the front line to optimize both our clinical approach and also our community engagement. So it's been really cool to kind of look at as we are turning the corner on the pandemic. And I don't want to say the pandemic's gone away. We, as a health department, it is incredibly present, but at the same time, we have other concerns that we are also trying to refocus on. How do we bring the knowledge and experience from that pandemic to these other efforts? So it's been really cool to try to look at that. I think one of the things that Charley talked about in terms of meeting patients where they're at, I think that's what the health departments have been doing for a long time. But now, especially for the Asian American and Pacific Islander community, I think one of the things that we have had to do and continue to try to do is try to be more culturally competent, both in terms of the care that we're providing to our clients, but then also ensuring that we are being culturally competent with our workforce. I think one of the things that the public health space has suffered from and continues to suffer from now is that we just don't have a large enough healthcare workforce to fully staff the public health agencies even right now, or for a potential need to scale up should there be another response that the public health sector needs to mount. And so it's one of those things where we have to be culturally competent, both in terms of the care that we provide, but also for the types of organizations that we run and how we can innovate in that space to ensure that we have long-term retention with folks that have tons of institutional knowledge. So yeah, I think that I'm looking forward to this conversation and providing kind of a public health aspect to it.
All right. Well, thank you so much, Sean. And Iami, you're with a health center, a health system. And so definitely as as the health workforce has been struggling, you're trying to be sure you take care of the patients. What kind of innovations have you been involved in? Tell us about your innovation journey.
Yeah, absolutely. So, we are a 9-hospital nonprofit health system in the Metro New Orleans area. And we went through a lot of growth last year. And with that growth, I think it's always important that we take a second to evaluate and analyze what can we be doing better. We have an opportunity to transform, given our recent growth, given that we're coming off of several years of the pandemic. What can we be doing as your healthcare provider and as a major health system in New Orleans to improve public health? And so I love hearing more from Charley and Sean. I consider your counterparts in New Orleans my partners. We do a lot of work with our pharmacy teams, our retail pharmacy teams on site, and with certainly with public health. One of the areas that Charley talked about is just how the pandemic gave rise to a lot of innovative ways of reaching people. And that started with the pandemic for us as well, with really concerted efforts to use data and go into communities of color like New Orleans East or the West Bank of New Orleans, where there's a heavy Vietnamese American population, and bring mobile community testing for areas that we knew people did not have access to public transportation. They don't own cars. There are language barriers. And so really providing, I think, as you said, Charley, equitable access. That's our responsibility at the health system. And it's something that I've brought with me from my time in government. I should have started off by thanking APAICS, an organization I've been familiar with for almost 20 years. They do such important and really good work. And, it's a constant journey to be able to take the experiences that I've had in my 11 years of public service at the federal and local level and apply it to, we're private sector, but we're nonprofit, apply it in a totally different industry, and one that has been incredibly important, and that's been through a lot of stressful times in the last few years. You mentioned with workforce, that is not unique to us. That is a national issue. There's just a national labor shortage, and trying to be really creative and innovative about how we reach new recruits and how we speak to RNs and letting them know about our mission. And, we're not going to outcompete some of these nurse agencies that are out there that are paying nurses $200 an hour. We are going to compete on our culture because as a nonprofit, we know that our mission, our vision, and our values are really appealing to people, and more people want to re-enter the workforce to join an organization that they believe in. We're all going to work hard, but let's be excited about the mission and be optimistic about the future.
All right. Well, thank you, Amy. And, you talked about the workforce. We know our community was actually impacted even when the pandemic happened, even before any public health orders, because unfortunately, because of discrimination, other types of things. So Karen, you're a senior economist, economic end of things. And I have to admit, I don't know as much about Grail as I should. So tell me about what your work has been in innovation at Grail.
Sure. First, I've been in the healthcare industry for over 20 years and just made the leap over to Grail about 4 years ago. And it was exactly for, it's like the purpose of this panel, which is innovation. We've been, a lot of companies are out there, but Grail, they are actually a company that's developed a platform and have invested, forward investment in really developing technology that can detect over 50 different cancer types using a single blood draw. I've been working for the CAR-Ts and multiple different cancer therapeutics, but I think this is really the area that we can really make a profound impact. And Grail is right there, supporting, their big mission is really to detect cancer early when it can be cured. It's an audacious mission, but I think this is where we can have, the biggest bang for our buck. They have used, it's so creative and it's so innovative. The platform that they've developed, it uses next generation sequencing with machine learning so that through this, 2 tubes of blood, we can identify the presence or absence of over 50 different cancer types. And after that, localize the cancer or really detect the cancer signal origin, which then can point to and facilitate the diagnosis of cancers. So, I was super excited about that. I think it's especially relevant since, we found that in Asian Americans is kind of the one racial ethnic group in the U.S. in which cancer is the leading cause of death. That was, really amazing. And really, it's like a statistic we need to change. And it's also important because with regard to the Native Hawaiians and other Pacific Islanders, they're also much more likely to be diagnosed with late-stage cancer. So I think particularly in the AAPI group, this innovation, we really need it to, kind of take hold and spread and be available to really reduce these disparities of care that we currently face.
No, I really appreciate that, Karen. I think talking about, so cancer is a leading cause of death, as well as the fact that we have a different profile for cancers, right? Particularly GI cancers are more prevalent in the API population. So, Naomi, I'm going to have you lead on the next round of questions. So, when we talk about innovation, what are the opportunities and future possibilities that our community should be looking for in healthcare? What do you see? And then also, what are some of the barriers to our community being able to benefit from these innovations? So, you want to lead off on that?
Yeah, and I just wanted to follow up on what Karen was describing. So first, Karen, I definitely want to connect with you after this call because it sounds super interesting what you're working on. And we have a cancer center with Louisiana State University that I'm sure would be very interested in learning more. What I think the opportunities are, Dr. Pan, are, this exchange of ideas is so exciting. There's so much capital in the innovation industry in general. There's a lot of investments being made. There's a lot of people who need proof of concept. And I think that goes hand in hand with the barriers, because I think this is not unique to my health system. So this is not me complaining about my coworkers. This is any major health system in the country. There is this feeling of, we don't need to look at that. We have X, Y, Z. We don't need to change how we're doing this, and we're fine as is. And I think it's my responsibility as the executive here with, responsibility for innovation, that we are giving everything a fair shot and looking at things that are really going to make a difference on health disparities, because there are a million, someone used the word bright, shiny objects. There are a million of those. Who a lot of them help? People who are commercially insured who are relatively healthy. And so I'm super interested in innovative products and processes and ideas that are going to speak to communities of color and help us reduce what we know in our community, in our state, is a tremendous health disparity in cancer. So I want to thank you for the work you're doing, Karen.
Yeah, glad to touch base. Yeah, we're really excited about it because I think it's like replete with opportunity in terms of really getting to this community where, we know cancer screening rates are also very low. So there's a lot of, I think, factors that go into it. But if we can actually offer some opportunities and do some education, I think this could be tremendous for this group.
And Sean, because you, in your presentation, we talked a lot about COVID because you're on the front lines, but you also made a point about, well, there's all these other things we do in public health as well, right? It's not all just about COVID or even contagious diseases. So
exactly.
You want to try to address this question about?
Yeah, so I think, Ayami brought up a wonderful point about talking about folks that don't have great insurance. And I think like the Affordable Care Act has done a lot of work to bring folks into the insured population. But from the health department perspective, we're still looking at folks that are uninsured or underinsured as our primary clientele for clinical services. And then we have individuals, even if they are insured through an employer, it's at the lowest potential level. And so they're still reaching out for supplemental health services or women, infant, and child services. And so I think one of the things that that is both a barrier and an opportunity for what we're trying to do is, I think what we'd like to do is adopt a lot of the technology. So it's like Karen was talking about using machine learning for a large data set to then understand and optimize for cancer characteristics. Well, the public health departments in the Commonwealth of Virginia have troves of data that's held, but it's all on paper. And we have this massive opportunity to digitize that information and then try to analyze it. But at the same time, like when you have filing cabinets and filing cabinets and filing cabinets of data, and that's one health department in one city, and there's 30 plus health departments in the entire Commonwealth, that is a time and person investment that the department needs to make to kind of access that data. So I think one of the things that we look at is those are amazing technologies. Could they be deployed for the uninsured and underinsured populations that we're seeing and oftentimes seeing for multiple years on end for continuing care, be it for chronic diseases or for STI care or just larger sexual reproductive health? There's a great opportunity to leverage those technologies. But again, for the populations that are walking in our door, and then once they're done walking in our door, how do we go to their community? We do a lot of newcomer health, and newcomer health in terms of first generation immigrants, refugees, or people that have been displaced by any kind of either natural or man-made event that have commuted to our community. How do we assist them and kind of get them ready to go? Be it get their kids immunized so they can register for school and get their kids into school, or if they need to have their health checkups done so they can then qualify for like refugee assistance and kind of get into the job programs. All those opportunities are folks that have no insurance, but could benefit from all this advanced predictive care and decision-making support, but it's just not available in the public health space yet.
Well, thank you, Sean. I want to go to you, Tonia, because we're talking about cancer, we're talking about, but I'm sure you see similar things in the obesity space. So, can you speak to the barriers and the opportunities? I don't want to just talk about barriers, opportunities and barriers in the obesity space.
Thank you. So definitely obesity is related to cancer risk. We know that obesity is actually associated with 240 plus medical diseases. What concerns me about the API community is that for Asian Americans, we're really at higher risk for metabolic disease, such as diabetes, high blood pressure, strokes, cancers, fatty liver disease at much lower BMI thresholds. So the World Health Organization has actually redefined BMI thresholds for Asians where overweight starts at just a BMI of 23 and obesity starts at a BMI of 27.5. So these are drastically lower than our standard BMI ranges. So I think part of the barrier is that I think not only are patients unaware of this big discrepancy, clinicians are also unaware. And I think we're missing a lot of disease where if they were caught early, definitely, as we've mentioned before, we see a lot of improvements in outcomes. And I would say more specifically, as far as access to medications, this is a big problem because right now, anti-obesity medications are only available if you have a BMI greater than 27 with a comorbid condition or BMI greater than 30. So this really excludes most of our Asian Pacific Islander population, even though they need to have that disease treated earlier. And more specifically, our newer class of medication, which is these once a week injectable medications that mimic how our guts hormones help us with weight loss naturally. So specifically, I'm referring to semaglutide available for FDA approval for weight loss. These are medications that have great benefits beyond weight loss. There's actually great major adverse cardiovascular event reduction by like 14%, along with reduction in, prevention of diabetes, which is great. And then also helps with improvements in blood pressure and whatnot. So I think these are all areas where hopefully if we got more interest for targeting therapies earlier in Asian Americans, we would have fantastic health outcomes.
Oh, fantastic. And Charley, you're with Walgreens, and we talk about, pharmacies being at the front lines. Well, we hope every neighborhood has a pharmacy, and we know not everyone does, but certainly there's more pharmacies than most other health institutions around. Can you address maybe some of the barrier issues that you've seen as in your role?
Sure. And, maybe I'll bridge a little bit from the prior question on opportunities. Sean mentioned something that, in going back and looking at the pandemic, what can we take from how we performed there and the lessons learned? It's such an important concept to think about in emerging from this. And it kind of goes to, IAMA made the comment about their setting of all the clinicians and the pharmacist included working together to deliver multidisciplinary care. I think that really is at the heart of maybe where the barriers are. We should be moving towards a value-based care system that allows all providers to work together in a physician-led model, but that gives us the opportunity to provide the best level of care and one that actually affects outcome. Where I would say the policy infrastructure sort of lets us down is it does not create a seamless ability for those providers to come together and do that. You mentioned pharmacy, Walgreens in the neighborhood, just a couple stats I'll riff off. 90% of the US population lives within 5 miles of a pharmacy. 95% of the AA and NHPI population live within 5 miles of a pharmacy. During the COVID pandemic, towards the latter stages, 70% of all of the vaccines that were administered were done so at a pharmacy. Pharmacies set up almost 20,000 COVID testing sites. So early on in the pandemic, they were very instrumental to making sure folks knew their status. High-risk Medicaid patients, they visit their pharmacy 35 times a year. Medicare patients visit their pharmacy around 14 times a year versus 5 times visiting their primary care in our more rural areas. So it just begs to say that the access point that a pharmacy is and the resource provider that exists within that setting is instrumental to making sure that we shore up the gaps in care. And I think the ability of pharmacists to work alongside the multidisciplinary team is going to allow us to get there. Right now, just as an example, within the Medicare program, pharmacists are not recognized providers to be able to deliver care. So when I mentioned that Medicare patient that comes in, that we should be providing perhaps a health and obesity screening and being able to refer them to Tonia. Or, if it's a cardiovascular or diabetes or cancer situation, which we just alluded to, how that is how our AA and HPI populations are disproportionately affected with those conditions. Our ability to do a simple screening that may be able to help us refer them to care, maybe it's within Sean's realm, or if it's IMA, or if it's Aaron, be able to link them to care. So right now that opportunity does not exist because pharmacists are not recognized providers. There is policy development in place. In the last Congress, there was a bill introduced that would recognize pharmacists within the Medicare system as non-physician providers. That will be reintroduced this session, and so we're hoping that that has progress. I think it would go a long way to ensuring that the pharmacist, the trusted pharmacist that is in these communities that we're seeing more and more is where patients are seeking care and they feel good about getting care in those settings. Having that policy in place will allow us to perform that function and work alongside the great colleagues that are part of this panel to deliver, again, that whole person care that really results in outcomes.
Well, thank you, Charlie. And I think the emphasis, though, should be on, is on the team, right? We have to, not people operating in silos, but together in teams. But talking about teams, Sean, I'm going to have you lead off on this one. So how can the public and private sectors come together, right? It's not all, I mean, we like to talk about innovation. A lot of times people say, oh, it's the private sector that does all the innovation. Actually, I think it's a combination of the two, public, private sector coming together to support innovation, to create those opportunities in healthcare. So can you perhaps speak to that as someone in public health?
Yeah, so I think we can look at the potential for collaboration between the private sector and the public sector from a couple of different lenses. I think the first is to directly piggyback on what Charlie was saying in terms of providing a full continuum of care and continuum of services for individuals, no matter their entry point. So there are products on the marketplace right now that allow for lack of a better term, a warm handoff between a pharmacist or a neighborhood provider, a health department, housing assistance, food assistance, that allows us to do warm handoffs and not create additional barriers for our clients. Because in reality, if you create any real friction for these clients, they're going to disengage with the system. And then we've just kind of lost the ball right there. So we need to reduce as much friction as possible to allow for folks for a full continuum of care process and allow for these warm handoffs. So I think there's an opportunity there for more private sector, both for-profit and not-for-profit entities to participate in these continuum of care circles. So be it the products that are offered to do kind of like case management or to actually just to do the client referral process. I think that's an area that's ripe for collaboration. I think the other part that I want to talk about was the private sector recognizing that while public health operates in the healthcare space, we don't have the same operating constraints that a hospital system like IAMA does, right? Like we are under completely different procurement processes. We're at a completely different level when it comes to technology adoption. And so I think it's one of those things where when we're working with the private sector, like I think we can utilize them to show us best practices and show us really cool ideas, but then also acknowledge that, hey, we can get there, but we're not going to get there in 6 months. It's going to take us a couple of years. So working with private sector partners or potential private sector partners that recognize that and can work hand in hand with a health department to get us there so that we can accomplish the same kind of outcomes that private sector providers and not-for-profit healthcare providers can do. So yeah, I think that's where I would kind of look at the collaborative opportunities.
All right. Well, thank you. Amy, I think you, how's your health system think about private-public partnerships?
Yeah, and I just get so excited about this topic because this is where I live. This is my experience. I really feel like I live at the intersection of public health and healthcare, just given my background and my current role. And we have numerous opportunities that target, social disparities, determinants of health, rather, in areas that we know are of serious concern that are contributing to health disparities in New Orleans. For example, partnering with the health department on gun violence prevention efforts, partnering with the local health department on universal postpartum home visits for all moms, regardless of their insurance. We have a literacy partnership. We just wrapped up Mardi Gras in New Orleans, and we provided all of the first aid in partnership with the city of New Orleans along all of the routes. And so this is part of what makes my job so exciting is I get to really leverage the reach that public health and the great reputation that our city of New Orleans Health Department has and our State Department of Health. And we all share the same goal, which is we have accountability for all communities, regardless of your ability to pay or your background. It's, as a nonprofit system, we really feel that our constituency is the public at large. So that was well said by you, Sean. Thank you.
Thank you. Actually, Karen, I'm going to turn to you now because you're at a private sector company that's doing cancer screening, which sounds very public healthy. So how do you see from your company's perspective these public-private partnerships?
We feel like the public-private partnerships are really imperative, really, to get the benefits, of this kind of technology more broadly dispersed. It's, so it's not only a matter of getting commercial coverage for those with insurance, but it's also working with the public sector, and our government affairs group, has recognized this, and they're working really hard to try to really get this implemented in kind of the Medicare, Medicaid. So it is an uphill battle, because it's a change in paradigm and innovation is always, people feel can be very disruptive, and the tendency is to stay with the status quo. So I think these partnerships have to be very, very tight in order to really accelerate the diffusion of these technologies as much as we can. So yeah, we can't overemphasize that enough for really getting this out there.
Great. Charley, did you want to comment? I mean, you're again with a private sector corporation, but yet you've talked so much about your public health work that the Walgreens has done. So do you want to address this issue?
Yeah, sure. I think there is so much that can be achieved from the public-private partnership. When we think about, the vaccine campaign and how we arrived at a vaccine and how we were able to distribute that across the country to the tune of nearly 700 million shots have been administered. It showed that the strengths of each sector were able to come together, and we were there for one purpose. So I absolutely feel like more of that should happen. We should see policy that enables that. We should learn from each other, and we can go a lot further than where we are today. I think, an organization like ours and what Sean does, working together to, sort of really understand the patients that need help and need care. Ayame mentioned it. We haven't talked about it much on the panel, but the social determinants of health, how important that is. When we think about whole person care, it really is not just their medication that you're handing to them that day, but it's understanding everything that goes on in that patient's life. We had a patient that came to get a vaccine. It was close to 9 months after the vaccine had become available to the public. And just in talking to that patient to find out why it took them so long, perhaps they had other reasons, but it was simply because they could not get transportation to a pharmacy that was not too many miles away. So something like that is so overlooked. What we were able to do is put in place a program where we partnered with Uber, and we were able to create rides for those people to come to the pharmacy and get their vaccine. But it was learnings from the data that came through departments like Sean's and of course through HHS that we were able to bring together and say, where are those patients that are falling through the gaps? How can we reach them? How can we reach them in the way that they want to be reached? And because of that, I think we gained a lot of success. And so as we apply those lessons to other campaigns, to other populations, to other health realms, we will only achieve greater success.
Okay. Wonderful. So we just have a couple minutes left. We're going to put each of you a little bit on the spot, give you 10, 20 seconds of concluding thought if you want, so a couple of sentences. And again, I too want to thank APAICS for convening this panel and doing on innovation, and really appreciate this opportunity to have this conversation. So I'm just probably just go down in order. So Charley, I'm going to put you on the spot first. Maybe you're a few sentences of concluding thoughts from you.
Yeah, again, a great conversation, great panel here. I think let's use this opportunity in learning about patients and the opportunity through innovation to really get people excited about their healthcare. Let's get them activated and want to participate in healthcare and how they will spread that message throughout their population. So I'll leave you with that.
Thank you. Dr. Vinton, your concluding thoughts.
Yes, thank you. So I really hope that we encourage our patients, especially in the API community, to be more aware that they're at high risk for metabolic disease. So go get your annual physicals, go get your lab work done at routine time periods, and this will hopefully help improve your health outcomes overall.
Sean.
One, thank you for you, Dr. Pan, for moderating this panel and for everybody else being here. I think I would close with one item. If you're listening to this and you think of yourself as a problem solver or as an innovator, no matter the industry that you work in, please apply for a job in public health. We could use you. It's that simple. we will be solving problems from day one till the day you retire. And it is an amazing feeling.
Ayami.
If you are a nurse listening to this, I have a job for you in New Orleans. All kidding aside, I do love the diversity of this panel. And my only parting thought is that none of us can do this alone. Innovation is a big nebulous topic that I feel like in healthcare is really only just getting started, and all of us have a role to play. So the more dialogue we can have like this, where there's an open exchange of ideas and we're building relationships and new avenues, that'll benefit hopefully access for a health system like ours. And access will bring more equity for especially the underserved community, which there are a lot of in New Orleans. So thank you again for having me.
Thank you. And Karen.
All of it was very well said, but I agree with we really do need to embrace innovation. I mean, this is the way we're really going to be able to reduce the burden, a lot of the diseases and improve health outcomes. So thank you for this panel. This has been a fantastic discussion.
Well, thank you all so very much for this fabulous discussion, for taking the time out to participate, for sharing your insights and with our listeners. And I want to also thank APAICS for bringing us all together so we have this amazing conversation, all too brief, but a very important one. And so with that, thank you so very much. And again, this is Dr. Richard Pan. Thank you for joining us today.